Welcome, everyone. My name is Ross Upshur, and I'm the head of the Division of Clinical Public Health at the Dalla Lana School of Public Health. And I'm delighted to welcome everyone to this seminar on human rights and global disparities in access to COVID-19 vaccines. And we are very fortunate to have three exceptionally distinguished panelists who I will introduce very shortly. This seminar is being co-sponsored by the Division of Clinical Public Health and the Center for Global Health at the Dalla Lana School of Public Health. But before we commence, I'd like to start with the land acknowledgement, and I'll use the University of Toronto's land acknowledgement. And we wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this land. And I am indeed grateful to be able to work with my Indigenous colleagues in working forward to address the issues in the Truth and Reconciliation Commission report, particularly focused on health issues. And I think when we're starting to talk about disparities and justice and human rights, it's a particularly germane point of departure for reflection. So today we have, as I mentioned, three panelists. I'll introduce them in the order that they will be speaking, and it will be followed by, they'll be speaking for about 6 to 8 minutes each, and then we'll open for discussion. And I ask attendees, if they have questions, to put it in the Q&A function, and we will, if you like a question that's there, please give it a thumbs up, and questions that are upvoted will be asked in proper order that way. So our first speaker is going to be Lisa Forman, who is an associate professor here at the Dalla Lana School of Public Health. She's also a Tier 2 Canada Research Chair in Human Rights and Global Health Equity, and has a distinguished academic career with multiple publications exploring the intersection between human rights and health. Our second speaker will be Bruce Porter, who's the Executive Director of the Social Rights Advisory Center. He's also been the advisor to the UN Special Rapporteur on adequate housing, and has an exceptional career in terms of advocacy and human rights, including many cases that have gone to the Supreme Court of Canada. And last but by no means least, we have Aruna Kashyap, who is the Associate Director for Business and Human Rights Division at Human Rights Watch. And she has extensive work, done extensive work on corporate accountability and human rights and global supply chains, and has had quite a career in different international settings. So three speakers, an important topic, and I can't think of a more timely issue to discuss today. So without further ado, I'm going to hand it over to Professor Forman. Lisa, the floor is yours.
Thank you, Ross. It's a tremendous pleasure to participate in this discussion. This is a topic very, very close to my heart, and I want to particularly thank Professor Shaza Fadel for very persistently ensuring that this event happened, and also thank Ross and Erica for co-sponsoring from the Clinical Public Health Division and the Center for Global Health. I'm going to talk about research that I'm doing under a Connaught Global Challenge Award on rights-based approaches to COVID vaccines, which rests on earlier work that I've done in my career on this very topic during the AIDS pandemic. During HIV and AIDS, we saw human rights and the right to health play crucial roles in advancing access to affordable antiretrovirals. And we saw how social movement were able to use human rights standards and framing and strategies to shift what was a complete refusal in the global political order to allow cheaper antiretrovirals in low and middle income countries. And social movements using human rights were able to achieve a really remarkable about turn and acceptance globally that universal coverage of antiretrovirals in low and middle income countries, and particularly in Africa, was an appropriate and a feasible goal. And their public health impact was enormous. We saw antiretrovirals rolled out through sub-Saharan Africa, and this fundamentally changed the trajectory of the AIDS pandemic and of AIDS-related illness and death on the continent. And more broadly, we saw the global legal and political order have some recognition that access to affordable medicines is a fundamental part of the right to health that requires global action when it comes to ensuring that pharmaceutical patents don't overly constrain low and middle income country policymakers from assuring universal access to essential medicines in health systems. But here we are in 2022, 2 years into COVID, where we are again faced with shocking disparities in access, particularly in the African continent, and where we have very little to show on the ground for the legal and political evolution around human rights and medicines and patents that we thought had occurred through the human rights struggles for antiretrovirals. I mean, and this is the reality of the world we live in right now, where COVID vaccines have been hoarded by wealthy countries, where the very fact of the pandemic is contested, democracy is in retreat globally, and efforts at international coordination and international law are disputed by right-wing pundits as a globalist plot to expand and make permanent the civil liberties abuses of COVID. And that last statement is more or less a direct quote that are due from recent pundit responses to a potential pandemic treaty that will try potentially to fill in some of the gaps in international law when it comes to pandemic response. So I think I don't need to make the point to a School of Public Health or to anyone watching this that the response to COVID has been politicized and contested at every turn in terms of what has been an effective public and global health response to COVID, and where human rights and international law are being portrayed as, in general, woke leftist plots and illegitimate intrusions into sovereignty. But I think the fact that Canada, a country that more or less explicitly supports international law and global action on COVID, the fact that Canada has been one of the worst hoarders of COVID vaccines tells us that right-wing politics isn't really a sufficient explanation of the disparities that we're seeing in COVID vaccines. And that the disparity is rooted in a tremendous lack of solidarity and global coordination that I think result from the hardwiring of a range of structural biases at the domestic and the global levels that have long produced inequitable outcomes and unjust disparities when it comes to the global distribution of power, money, and resources, and that show up so starkly and so horrifically when it comes to race, class, gender, and geography. And this is true whether we're talking about the historical legacies of colonialism or the endless, no limits expansion of neoliberal economics. These are the pernicious determinants of health inequities that the WHO Commission on the Social Determinants of Health alluded to in their seminal 2008 report. And the current disparities in access to COVID vaccines tell us that whatever we've done in the past decades to resolve those disparities have not fundamentally disrupted the political and economic power and forces that continue to reproduce health inequities at almost every turn. So let me quickly paint a picture of where we are right now in 2022 on access to COVID vaccines. So we have really an extraordinary array of vaccines in use and in development. 38 vaccines approved at the WHO, 195 other candidates, almost 700 vaccine trials. So this is, by any measure, an extraordinary and unprecedented timeline for vaccine development. In the year and a half since COVID vaccines began to be administered, around 12 billion doses have been administered globally. Almost 70% of the world has received either an initial or a full vaccination. So nothing short of remarkable progress in vaccination, but the global distribution is quite stark. Whether we're looking at vaccination with 1 dose, 2, 3, or 4, the African continent has by far received the least amount of vaccines. Only 22% of people across the entire continent have received any vaccines. Only 17% have received a complete initial protocol. And this at a time when many countries are administering third or fourth booster doses, when the death toll from COVID has been 4 times higher in low-income countries than in rich, and where in all countries serious cases of COVID and deaths are predominantly occurring amongst those who are unvaccinated. So COVAX was set up early in the pandemic in April 2020 to assure more equitable global allocation mechanism and to avert the kinds of vaccine hoarding and nationalism that we'd seen in previous pandemics, not simply in AIDS, but during the 2009 H1N1 influenza pandemic, when high-income countries bought up the global supply of the influenza vaccine, and UN efforts to have this resolved through donations were failed. But COVID has failed to meet its goals of assuring at least 20% of countries received vaccines, mainly because of vaccine hoarding, because of funding shortfalls, and because of inadequate donations. So vaccine hoarding has been a significant problem here. By the end of 2021, most high-income countries had purchased enough doses to vaccinate each person in their population 2 to 4 times over. And Canada, here again, it really is the worst culprit. In May 2022, Canada has purchased almost 419 million doses, enough to vaccinate each person almost 6 times over. We've also seen evidence of regressive pricing for low and income countries, where South Africa paid 2.5 times more for AstraZeneca than European countries did, and where Uganda, a low income country, paid 3 times more. And the scarcity is exacerbated by the lack of manufacturing capacity in low and middle income countries and the almost total failure of companies to voluntarily share technology or licenses, including through the COVID Technology Access Pool, CTAP, which was created precisely for this purpose. So it's not surprising in this context that low and middle income countries sought almost from the start of the pandemic to enable lower priced and locally manufactured therapies and diagnostics for COVID. So India and South Africa in October 2020 asked for global intellectual property rights at the World Trade Organization, not simply to be relaxed, but to be waived for the duration of the pandemic for COVID therapies and diagnostics. And this was a request that was widely supported by other low and middle income countries. Well over 100 countries backed this, as well as global civil society, precisely because these actors knew the extent to which their hands are tied when it comes to accessing or producing affordable medicines and vaccines. And this is primarily through the Agreement on Trade-Related Intellectual Property Rights, the TRIPS agreement at the WTO, that requires any country that joins the WTO to give very strict 20-year patents that prevent non-consensual use, enable countries to maintain monopoly pricing, and obviously drive up drug prices. TRIPS allows those rules to be loosened in service of public health, where countries can manufacture or import cheaper versions of patented drugs to meet public health needs. But the use of these flexibilities from the start has been highly contested, and during AIDS we saw countries blocked from using those flexibilities, and it was only through campaigns for affordable antiretrovirals that the right to use those flexibilities was finally affirmed in the 2001 Doha declarations. So while the flexibilities have offered some policy space for low and middle income countries to access more affordable medicines and vaccines, they are extremely difficult, time-consuming and expensive to use, and countries continue to face trade sanctions or corporate litigations when they try to do so, as was the case in India in 2012, in Colombia in 2018, Malaysia in 2017. They also have those flexibilities stripped away in trade and investment agreement. And the challenges have continued despite the fact that it has been continuously affirmed in global policy and law since Doha in 2001 that states have the right to use TRIPS flexibilities to the full to ensure access to medicines, from the 2008 UN Global Strategy and Plan of Action on Intellectual Property, Innovation and Health, to the 2016 High-Level Panel on Access to Medicines, to the 2015 Sustainable Development Goals, which explicitly include that states are entitled to use those flexibilities. So since October 2020, the waiver has been blocked by the EU, the US, and other high-income countries, and there is now a far narrower compromise text on the table that will be voted on at the WTO in mid-June. And the compromise dispenses with a waiver for all COVID-related diagnostics and therapies, and instead opts for a case-by-case government decision on vaccine manufacture only. Something some prominent IP experts have threatened suggests will be just a purely diplomatic compromise. So while the TRIPS waiver, I don't think anybody has ever suggested that the TRIPS waiver would have been a total solution to these disparities. It clearly would have expanded the capacity of low middle income countries to begin to scale up manufacturing capacity and to negotiate for better collaboration, coordination, and tech transfer from high income countries and pharmaceutical companies. And what's really remarkable and extremely disheartening is to see how the arguments that have been made really have echoed the arguments that were made and thoroughly disproved in HIV, that strict intellectual property rights in low and middle income countries play an essential role in sustaining or promoting the innovation of new medicines, and that the solution lies anywhere but in loosening those rules. I mean, and this comes at a point where the evidence is, I'd say, fairly clear that low and middle income country profits from patented medicines have zero impact on pharmaceutical industry innovation for the diseases of those regions, that public funding often significantly subsidizes corporate R&D, which was certainly the case for COVID vaccines, where Forbes estimates that 98% of R&D for COVID vaccines from all of the primary manufacturers came from public funding. And in a context where companies frequently game the system to maintain perpetual patents. So some medicines simply never move into the public domain and into competitive pricing. And I think one of the worst examples of this is insulin. This was developed over 100 years ago, sold to this university, the University of Toronto, for $1 100 years ago, yet today is sold in the US for hundreds of dollars a dose. So I think the disparities we're seeing around COVID vaccines reflect the larger problem of a global political and legal order that often favors commerce, trade, and industry at any cost to public welfare, and where stark disparities are sometimes seen as the natural consequence of doing business and not the responsibility of companies to resolve. We are not the Red Cross, is how Pfizer put it during the AIDS crisis. Yet in human rights, every life is seen as valuable and worthy of equal treatment and dignity, and every person is understood to hold entitlements to a just social order in which they can flourish and experience well-being, and in which their rights to life, non-discrimination, and to health carry implications for what states and non-state actors alike do. So even if Pfizer is not expected to be the Red Cross, it is also not acceptable for it and other companies to act without limits and absolute impunity where the life and health of millions are impacted so grievously. So today, more than ever, I recognize how naive and almost preposterous it probably sounds to suggest that human rights and international law are powerful framing tools and legal strategies to push back against pharmaceutical industries and their host governments, and to push for a more just global governance of health. But I think the AIDS experience lets us know that something is possible with human rights, that these norms and laws, in conjunction with effective social movement in particular, can help protect life-saving medicines and vaccines from unrestricted commodification and corporate control, and help push for more effective international cooperation and solidarity in times of crisis, and also help ensure that the global trading order doesn't tie the hands of low and middle-income country policymakers when it comes to meeting domestic public health needs during crises, so that we don't look to philanthropy, charity, or corporate largesse as solutions to inequities of this nature. So for all the weaknesses of the international human rights law system, I think their norms and standards of rights continue to offer legal tools and strategies that can do something effective. And the challenge, I think, going forward is to make these tools matters in cases like this, and to strengthen them so that they can more effectively respond to disparities of these nature, even if they cannot stop the perpetual reproduction of these inequities, and even in perhaps especially in a world in which human rights and international law are under such attack. I'll end there.
Thank you, Lisa. Now we'll pass over to Bruce. Bruce, the floor is yours.
Thanks very much, Ross. I'm speaking from Muskoka, the traditional territory of the Anishinaabe peoples, where I live and work. I'm really pleased to be here and really value the invitation to engage in dialogue, particularly with advocates for public health, because I see the pandemic as having revealed in a unique fashion the necessary convergence between these two fields of practice. So I'm really looking forward to the discussion. And Lisa has done a fantastic job of outlining the incredible crisis that we're facing that's certainly widely recognized as a public health care crisis around the mantra of no one is safe until everyone is safe. But as Lisa suggested, it also has to be seen perhaps more fundamentally as a human rights failure on a global scale, which has failed to recognize not only that that no one is safe until everyone is safe, but no one enjoys the fundamental human right to life until we're somehow able to ensure the protection of the right to life more globally and universally. The patterns of exclusion and deprivation that we've witnessed during the pandemic conform and exacerbate, as Lisa said, systemic global and structural patterns of inequality, oppression, and colonialism. As the United Nations Committee on the Elimination of Racial Discrimination recently said, the pattern of unequal distribution of life-saving vaccines manifests a global system privileging those former colonial powers to the detriment of formerly colonized states and descendants of enslaved groups. So these are the kinds of problems that we expect human rights norms to address and solve, holding governments accountable for decisions and policies that deprive vulnerable, disadvantaged, and oppressed populations of life, health, and economic security. This international human rights order was recently described by the Supreme Court of Canada as the phoenix that rose from the ashes of World War II. The court affirmed that these norms are not meant to be theoretical aspirations or legal luxuries, but moral imperatives and legal necessities. Governments have clear obligations under international law to protect and ensure the right to life, the right to the highest attainable standard of health, and the right to enjoy the benefits of scientific progress and its application. These are rights that have been ratified by Canada in human rights treaties that are considered binding in international law, though not directly enforceable by our courts. But it hasn't been easy to hold governments accountable to these obligations with respect to ensuring a globally inclusive response to the pandemic. A central challenge is that human rights in international law are generally, though not exclusively, considered as obligations of governments applying to those within their own territory and jurisdiction. It's much more difficult to hold governments accountable to violations of rights of those outside their territory. So while international law encourages international cooperation and assistance, it's difficult, or it has been in the past, to argue that the right to health or housing places an enforceable obligation on the government in Canada, for example, to ensure access to health and housing in other countries. So the state actions that have created and sustained global inequities in vaccines at the cost of millions of lives don't conform to the traditional model of governments violating the rights of other citizens, of their own citizens, at least not directly. Ironically, actions by affluent states like Canada to secure vaccines to protect the lives of their citizens could be viewed in a narrow sense as consistent with the obligation under international law to protect the right to life and ensure the highest attainable standard of health for those within its jurisdiction. So the really fundamental human rights challenge raised by the pandemic has been to hold our governments accountable to a higher order of obligation of international cooperation in the development of a truly global response that's ultimately the only way to adequately protect the lives of everyone, including those within Canada. Responding to this challenge has drawn us back to the foundational values affirmed in the Universal Declaration of Human Rights, that all human beings are born equal in dignity and rights, that not only civil and political rights like the right to freedom of expression, but also economic, social, and cultural rights like the right to health, the fundamental human rights, that all these rights must be subject to effective remedies. That is, we must be able to claim and enforce them and hold governments accountable. And perhaps most important of all in the present context is the affirmation in Article 26 of the Universal Declaration that we're entitled to a social and international order in which rights and freedoms set forth in this declaration can be fully realized. So all human rights norms, even if they formally apply only to residents of one country, are grounded in a broader commitment to an international human rights order based on shared commitments to fundamental human rights. This was really the origins of the UN, and it's really the foundational, the bedrock of human rights norms, which have been embedded, of course, in the Canadian Constitution and the Charter and so on. So this issue of accountability and commitment to international cooperation is a tough one for us to address within traditional paradigms, but it came to the fore, as Lisa noted, in the response of affluent states to the proposal for a TRIPS waiver to ensure access to COVID-19 vaccines, diagnostics, and therapeutics, and the ability to produce those within less affluent countries. The proposal, as Lisa noted, was supported by a vast majority of states and would have ensured that lower and middle income countries could mobilize productive capacity and produce their own vaccines, creating additional production, reduced prices, and more equitable access. Canada claimed that it doesn't oppose the waiver. It is still one of the few countries that has not voiced support, even after the Biden administration announced its support. And as Lisa noted, while the TRIPS waiver would not constitute an entire solution to the vaccine inequity that we're addressing, the lack of support from a few affluent states with plentiful access to vaccines encapsulated much of what has gone wrong in the global response to the pandemic, placed corporate rights to massive profits ahead of the rights of vulnerable populations to life and health. It placed the most critical decisions about distribution of essential vaccines in the hands of corporations with no accountability, and allowed affluent countries with disproportionate influence on the international stage to block a proposal with widespread backing and virtually universal support from the global south. It also provided concrete evidence of how international institutions like the WTO are failing to recognize that they too must be bound by fundamental human rights obligations. So as Lisa noted, the best way to achieve progress in human rights is to claim them. So civil society organizations mobilized during the pandemic to utilize any available mechanisms we could secure to challenge states blocking the TRIPS waiver and advance claims to a globally inclusive, equitable, and effective response to the pandemic. Urgent appeals and claims were submitted to a number of UN human rights bodies. The UN Committee on Economic, Social, and Cultural Rights, as a result, issued a statement clarifying that states have an obligation to cooperate internationally to ensure the right to health, not only within their own borders, but also internationally. And more recently, in response to an urgent appeal to the UN Committee on the Elimination of Racial Discrimination, that committee called on all states to be guided by the principle of international solidarity through international assistance and cooperation, including by supporting the proposal of a comprehensive temporary waiver on the provisions of the TRIPS agreement. Urgent appeals were also submitted to the UN special rapporteurs and independent bodies charged with overseeing compliance with human rights, resulting in formal communications being sent to a number of states that had been blocking the TRIPS waiver, including Canada, as well as to pharmaceutical corporations. And in addition, we developed a general framework for potential coordinated litigation in domestic courts in Canada, Norway, the UK, and Germany to challenge those states' decisions not to support the TRIPS waiver as a violation of not only domestic, but international law. All of this is critical work in progress, and I think to affirm a new and innovative human rights claim that governments can and must be held accountable to an obligation to address global challenges such as pandemics and climate change in a cooperative and equitable manner in line with fundamental human rights values. While Canada likes to portray itself as a firm supporter of the international rules-based order, its actions with the WTO and elsewhere often fail to put the rhetoric into practice. One of the important developments in international human rights law on the right to life and access to healthcare, in fact, was the case of Nel Toussaint versus Canada, in which the UN Human Rights Committee found that Canada had violated Ms. Toussaint's right to life and non-discrimination by denying access to essential healthcare to irregular migrants, even where their life is at risk. In both domestic courts and international fora, Canada has insisted that governments have no obligation to provide healthcare to protect the right to life, a position that puts it at odds with current international norms and most other jurisdictions. In the Toussaint case, Canada has responded to the UN Human Rights Committee to say that it does not agree with the committee's interpretation of the right to life and will not agree to change its law or policies to comply with the ruling. This is precisely the kind of disregard of evolving international human rights norms that we can no longer afford to accept, not in Canada or elsewhere. While international human rights norms are often not directly enforceable in domestic courts, they must, as the Supreme Court has reminded us, be treated as moral imperatives and legal necessities and implemented in good faith. A number of human rights organizations will be supporting this Toussaint in court on June the 13th in Toronto to challenge Canada's refusal to implement the UN Committee's decision as failing to meet that standard. This is a new and evolving area of law both internationally and domestically, but the pandemic has made it clear and prompted clarification that Canada and other affluent countries can and must be held accountable to the obligation to ensure the right to life and health through international cooperation and assistance. Human rights, like pandemics, cannot be defined or contained within borders. Demanding a new form of accountability for international human rights norms and international cooperation has itself become a moral imperative and a legal necessity, both for human rights advocates and public health advocates. Thank you.
Thank you, Bruce. Now I'll hand it over to Aruna, please.
Thank you, Ross, and thank you, Lisa and Bruce. I think the panelists who spoke before me really sort of laid out the international human rights frameworks really well. As the corporate accountability, person who deals with corporate accountability at Human Rights Watch, I will speak a little bit more to some of the aspects that Lisa and Bruce touched upon, which is, corporate control, the power of corporations, and how do we see the power of corporations vis-a-vis state obligations. As Lisa and Bruce laid out, one of the challenges in some ways is that international treaty obligations under the International Covenant on Economic, Social, and Cultural Rights, International Civil Covenant on Civil and Political Rights, these apply to state obligations. These are all obligations vis-a-vis states. And it's up to states really to regulate corporations. There are other guidelines issued by treaty bodies, essentially to look at what the responsibilities are of corporations. So there are two sets of guidelines here. One is the UN Guiding Principles on Business and Human Rights. And then there are the 2008 UN guidelines issued by the Special Rapporteur on Health. These guidelines are addressed to the responsibilities of pharmaceutical companies, specifically in relation to access to medicines. So in addition to what's laid out in the international treaties and the interpretations of the treaty bodies, these are the two sets of guidelines that are speak to the responsibilities of corporations. Now, under international human rights law, one of the things that we do have is, as Bruce mentioned, international cooperation to share the benefits of scientific research and progress is really central here. Now, there are two ways in which we've advocated as an organization, joining lots of other civil society groups across the world, is that one part of this crucial obligation is to ensure that states do not interfere with other states' obligations towards their own populations. And that's what we are using to advocate very strongly for the TRIPS waiver to be adopted as originally proposed by India and South Africa in October 2020. Now, in addition to that, I mean, the reason the TRIPS waiver is so central to the argument is because that's the only way to ensure that where corporations are not voluntarily doing things that's within their power to do, the one way to sort of ensure that existing international law in treaties do not interfere with the tie the hands of governments to take additional measures is to waive these additional complex rules laid out, intellectual property rules laid out in the TRIPS agreement. Now, there are two sets of problems here. One is, in addition to the problem of hoarding, the problem of hoarding is being replicated again and again. First, we saw in case of vaccines, then we saw in the case of mRNA vaccines. We're seeing this in the case of treatments like Paxlovid, which have been largely bought up by high-income governments. Again, we're seeing huge disparities in access to testing. So the problems of disparities in access is affecting not just vaccines, but as well as treatments, life-saving treatments, as well as testing. Testing is critical as a method of control, infection control, as well as in order for governments to be able to ensure that people have access to treatments. For example, for Paxlovid to be given to people, they have to be tested. So unless there's wider access and equitable access for testing as well. And it becomes impossible for governments to sort of control as well as treat populations based on existing, WHO recommended treatments. Now, when Human Rights Watch sort of, in addition to advocating for the TRIPS waiver, there are two, coming back to what's voluntarily possible by governments, we've looked at the UN Guiding Principles on Business and Human Rights. What the UN Guiding Principles on Business and Human Rights say is that companies have the responsibility to voluntarily conduct risk assessments in their own operations. So how do their business models in the current pandemic serve public good? So is their business model exacerbating the risk of supply? Is it exacerbating risk to pricing, affordable pricing for different countries? Is it exacerbating the risks of the transparency or a lack of transparency? Those are some of the key risks we looked at. Now, in terms of what companies can do, there's a lot they can do. For example, they can voluntarily offer their technology, the vaccine technology, to manufacturers around the world. In fact, we worked with two experts to say, to show that there were over 100 manufacturers, potential manufacturers, with the ability to produce more mRNA vaccines and produce them widely around the world to distribute them across to a lot more governments. But till date, we are not seeing that kind of expanded sharing of vaccine technology voluntarily with any of these manufacturers that we've identified. But in addition to which, Lisa mentioned that there are pools, technology pools that have been created. So in the case of the mRNA vaccine, which is Pfizer and Moderna's vaccine, BioNTech Pfizer's vaccine and Moderna's vaccine, the WHO created a specific technology hub called the mRNA COVID-19 technology hub in South Africa. Now, none of these companies have voluntarily offered to share their technology with the WHO mRNA technology hub, which has left the hub to reverse engineer this vaccine and to try and develop a vaccine on its own. Now, that's taking a longer time. There has been progress, but in order to develop a vaccine, the clinical trials need to be conducted, additional approvals need to be sought. So what the lack of sharing has done is it's just increased the time it will require for the technology hub to scale up the production and share the technology widely with other capable manufacturers around the world. So we can see on the one hand that the power of corporations when they don't voluntarily share what they can do, it impedes the success of hubs such as those set up by the WHO technology, by the WHO. The other problem here is when we wrote to the government. So for example, we wrote to the US government as well as the German governments to say that, they have publicly funded the technology, big aspects of the IP undergirding the technology in many ways and the development of the vaccine itself. And that, therefore, they have the power to use their funding in order to attach conditions in relation to sharing of technology. But neither of those governments have stepped in to require that kind of sharing of technology. So once again, the sort of tension between what companies are voluntarily capable of doing and not doing, and as well as state obligations, and what happens when states don't step in and exercise that or implement that obligation or take measures in line with the international obligations, human rights obligations. In this particular case, we are not seeing that kind of exercise of power by the US government or the German government. A big part of the problem here in relation to the failure to require companies to share technology is also what the companies are saying. So there are, for example, companies saying, we are providing vaccines at non-for-profit prices to COVAX. COVAX is this international procurement mechanism that has been created by Gavi and CEPI, which are public-private partnerships. It's in the nature of a public-private partnership. Now, the real challenge is in the absence of any information about the precise costs that companies incurred in developing the vaccine, it becomes impossible to gauge or verify what a non-profit price means. And therefore, so there's no transparency in this process at all, and companies are not volunteering information about the research and development costs that have been incurred by them, they're not voluntary, they're not disclosing what this nonprofit price is, they're not disclosing or as yet to disclose whether this has been, any third-party audit has been conducted on this nonprofit price and what the findings of the audit are. And these are some of the questions that Human Rights Watch posed to these companies. And we are yet to see sort of any sort of meaningful disclosures in relation to any of these questions. Now, one of the problems here, again, coming back to sort of the tension between what is international human rights law require, for example, the UN guidelines, the Special Rapporteur's guidelines in relation to pharmaceutical companies says pharmaceutical companies should disclose as much information as possible about pricing and so on, but we're not seeing that kind of voluntary transparency or disclosures from companies. And we're also not seeing, for example, good practices being followed. Now, if you look at good practices in procurement, for example, UNICEF has a pricing database for all of the vaccines it procures, as well as medicines. Now, in the case of UNICEF, what they do in the pricing database is they actually publish the prices at which those vaccines and medicines were procured. We're not seeing that kind of transparency in COVAX, and neither are we seeing that kind of transparency from any government. Most governments are not disclosing it. What we are left to rely on is investigative journalism, some leaks, perhaps some activism using right to information to try and seek this information, but that's not good enough. So what we need is sort of regulatory frameworks to change in countries to require transparency around research and development costs as well as procurement prices. And unless that kind of regulatory framework dramatically changes, it's going to be this constant tension of requiring, pressing governments to comply with their international human rights obligations, asking companies to do what they can do voluntarily. But then when we go to companies asking, of course, that they voluntarily comply with some of their responsibilities, it's up to the company really, and the company continues to remain in control about whether they want to disclose or not disclose. So in substance, one of the key things I think the pandemic has revealed is a need for a lot more stringent regulation, and it's not even stringent, a very basic level of regulation requiring transparency about procurement prices, about R&D costs. And there are not a lot of laws in this place. There is some advocacy, but we still need a lot more sort of regulatory frameworks to require companies to do the right thing, where they don't voluntarily provide adequate information to stakeholders being both access to medicines groups, patients' rights groups, as well as independent groups, independent human rights and other civil society organizations. The one other aspect in terms of the risk to companies themselves, as well as the risk to populations, is that what are companies doing in order to bridge the gap, bridge the disparities between high-income governments, even within high-income governments, what are they doing to bridge the gap between those who have access and those who do not have access? And we see a lot of populations, especially people of color, indigenous communities being excluded. And similarly, this exclusion plays out along racial lines, because a large part of the world that has been excluded and left behind, because those governments do not have the power to outmatch and outbid high-income governments, are the low-income governments predominantly catering to Black and Brown people around the world. So this disparity has played out in racial lines, and that is a significant risk to companies to have the essential drugs and medicines be distributed only to certain populations and not others. Again, coming back to what can companies do to address this risk, they can voluntarily sign up and share their technology with the WHO mRNA Technology Hub. They can share their technology and their IP with the COVID-19 Technology Access Pool, again set up by the WHO. They can share their technology, as has been done in some cases with the Medicines Patents Pool. Now, there are certain limitations to voluntariness, which also should be highlighted. For example, a lot of people have read, excuse me, that Pfizer, for example, came forward signing agreement with the Medicines Patents Pool. And this was a voluntary license that they signed with the patents pool. Now, that is a good step forward, but there's a big but here. There are a number of countries were excluded from the license. So, for example, one of the terms of the licensing agreement was that the drug that Pfizer had manufactured, had developed, could only be licensed and then marketed in 95 countries around the world, and large parts of the world were left out. For example, countries like Brazil, which have really suffered with COVID, have been left out of this. Now, Pfizer has signed another intent to supply with the Global Fund, but again, it's yet to be examined when that agreement will be finalized, how many countries additionally will be supplied, and who that agreement will exclude and include. And that's again only 6 million doses that Pfizer has agreed to supply, signed an agreement with an intent to supply. So there are certain limits to voluntariness, and those limits are, and the biggest limit is that it's really up to the company to decide who and where they will license. There is some opportunities to negotiate, but again, the power vests with the company, and it's up to the company to decide who and where and how they will license their product and their IP. And that's the key impediment to sort of really scaling up the availability and affordability of either treatments, but also testing and vaccines. Now, if we want to fundamentally sort of dent this, if we really want to shift it, the power can shift, and the one solution really is the WTO, the waiver that everybody has been pressing for at the WTO. What the waiver will do is sort of create the space for governments who want to issue compulsory licenses or want to compel the production or create more space for production in their own countries, or even export and import. So it's not limited to any one government or one country, or the production is not only held mostly in the US or in Europe, but it also shifts to other countries across Asia, Africa, and Latin America. And that's central, sort of shifting the production and decentralizing production, creating diverse hubs across the world that can really sort of scale up production is so central as a response to this pandemic. And that can only a key tool for this to happen, or to at least pave the way for this to happen, is the WTO TRIPS waiver. Thank you.
Thank you, Aruna. And I encourage now participants and attendees to contribute their questions. And I want, just before we turn, we have a couple of questions in the Q&A, and while people are formulating their questions, if any of the speakers would like to comment or reflect upon any of the other comments that they'd heard from them. So just as a moment, if anybody wants to clarify or ask clarificatory questions or additions to what's been said so far. Nope, everybody's good to go to questions. Fantastic. So the first question we have is, could any or all of you address how, when resource-rich countries did share, they sent vaccines that had a more challenging safety profile or less effectiveness? And how does this not perpetuate suspicions of developed countries experimenting on those less developed? Does anybody want to take a crack at that? Lisa or Bruce or Aruna? So the practices that were observed when it came to sharing vaccines seem to have had some issues in them. Lisa, I see you've unmuted. Go ahead, please.
I mean, I think that's an excellent example of both the inadequacies of global cooperation and coordination, the inadequacies of a philanthropic response, or one that's based on the donations of excess vaccines by high-income countries who had enormous quantities of these. So I think that example is a really good example of how deficient that response was. I mean, when you do have countries donating vaccines that are on the verge of expiration, that virtually cannot be used, how can it do anything but create mistrust? How can it be anything but kind of an inadequate PR exercise? I completely agree with the question that these types of efforts don't garner trust.
Great, thank you, Bruce or Aruna. Do you want to add on to that answer?
I mean, I'd just say it is an excellent question. I have to say that we don't necessarily always understand as well as we should in the Canadian perspective just what it feels like for residents of emerging economies and developing countries, the pandemic is worse than sort of making them suspicious of affluent countries. There's an incredible offense in the way the whole thing has been handled. So there's a lot of distrust and anger, but it's going to take a very long time to overcome. It's just such a horrible example of countries that tend to be self-righteous about their human rights records, just completely ignoring the human rights of others and discrediting their record in a really serious way. And I think we just don't think enough about what it feels like to be deprived of access to vaccines or handed them a few less effective ones by countries like Canada that are sitting on massive surpluses. It's done a lot of damage to international solidarity.
Thanks. I apologize for the background noise. I was afraid it was my dogs that were going to make noise, but our neighbor has decided to take a chainsaw to the tree. So I apologize for the background noise. Rita, would you like to add to that answer?
Yeah, I mean, just to reiterate that I think a donations-based approach is very limited. I think a big part of the problem is also when countries decide to donate. But in the longer term, I think the problem of relying on a donations-based approach is that we don't really allow low and middle income countries to be self-sufficient and be able to produce and cater to their own population. So they're completely dependent on high-income governments for life-saving vaccines, treatments, and that's not a sustainable model of for them to discharge their obligations on the right to health. I think equipping those governments to also protect their own populations, the only way that will happen is if there is expanded production capacity in various parts of the world, and production is not controlled only within the territories of high-income governments. That's the only way this can be sustainably solved.
Thanks. So knowing that this is a school of public health, and I'm looking at the attendees, there's a large number of people actively engaged in public health. I'd like to take the opportunity to ask the panelists, all of whom have extensive experience in human rights law and human rights advocacy, what sort of things they think that public health schools or public health professionals could do to be greater allies, for example, in some of the civil society activities that you've outlined and discussed. So how can schools of public health help advance a human rights agenda for health? Any takers for that?
Well, I'll go first. There was, it's actually been incredibly helpful to have mobilization of healthcare workers and public health advocates around some of the fundamental human rights issues that we've been dealing with. Our International Nurses Union actually filed a petition with the Special Rapporteur on the Right to Health and got a really important response. And so I think it's a matter of what I was talking about, this kind of convergence of public health advocacy and human rights advocacy, where public health advocates can really insist on holding governments responsible for access to healthcare as a fundamental human right. And human rights advocates can do a better job of understanding the obligations of international human rights through the lens of the necessary positive measures that have to be taken to protect public health, not only within borders, but internationally. So I think there's a lot of room for a really constructive dialogue between the two. And just in the Toussaint case that I was referring to, that was the one sector that was incredibly supportive of Ms. Toussaint. There were demonstrations organized by healthcare advocates and workers across the country protesting Canada's refusal to implement the decision. So this link, it's so clear to healthcare advocates that the right to life, that you never deny access to healthcare as some sort of in an unequal or discriminatory fashion for any reason. It's beyond that kind of consideration, and so they've been incredibly important advocates for the right to health as it properly understood under international law.
Lisa, did you want to jump in?
Well, I mean, that question I feel like has been a fundamental one. I'm a lawyer at a school of public health. So I think, one of the things that would really be be helpful is a broader recognition in the scholarly and research and education domain of public and global health that law is relevant. It is a determinant of public and global health. I mean, there was a wonderful commission, Lancet Commission a few years ago, on law as the determinant of health. You know, law shapes policy, it shapes programs, it shapes outcomes. And one of the the Lancet Commission on the Legal Determinants of Health is, I'd say, a must-read for anybody who works in this field. And one of the things that it recognized was that law and health are fundamentally intertwined, and that we just are not doing well and enough when it comes to training lawyers around public health and training public health people around law. I mean, in Canada, I think Dalla is maybe one of the only schools in Canada that has any training on this. There's just an absolute deficiency. There's a deficiency of training. There's a deficiency of programs. We're not creating graduates who can go out into the world armed with the tools of both of these critical disciplines, with the ability beyond sort of, you know, a normative commitment to human rights, with the ability to mobilize and implement the standards and the tools of both those disciplines when it comes to these kinds of. So I would say that is absolutely fundamental to people from schools of public health and law schools out there. This is something you really would be it would be fantastic to push for that.
Well, I'll do everything in my power. Aruna, would you like to chime in on that? Because I can see some future webinars on law as a determinant of health to get greater sensitivity to it. Aruna, would you like to have the last word on this issue?
No, I couldn't agree more with Bruce and Lisa. I think the intersection of law and public health are really critical. Public health experts can actually provide some very interesting ideas for the types of law reform also needed, especially in the areas of public procurement during emergencies, the types of critical changes that are needed, but not just sort of push the normative framework through, developing better norms, making sure they're implemented through various commissions or public hearings and studies and data gathering exercises, but also to influence how lawyers think about some of these subjects. And the critical question of disparity in access and equitable access is really something that can shape this intersection of how law interacts with public health and vice versa. And I couldn't agree more that confluence is really critical at this point.
Oh, excellent. Well, unfortunately, we're at time and now the questions are coming in, but I suspect this will not be the last webinar we have that looks at the intersection between law and public health. I'll try to twist the arms of the three of you to return at some future date. There is a question on the pandemic treaty. I think that would be a great topic for a future webinar if and when it evolves. So we are at time, and unfortunately we have to all good things must come to an end. So I would really like to thank our three panelists for an absolutely stimulating seminar and discussion. I think we've just scratched the surface of this intersection between law, human rights, and public health, and I'd like to encourage our school to pursue this in greater depth. I teach a course on the history of public health, and it struck me how much legislation and regulation has shaped health from the 19th century through to the 20th century. So I think this is something that schools of public health should feature more prominently. So I'd like to thank Bruce Porter, Aruna Kaishap, and Lisa Forman for their contributions today, to the attendees for their attention and their questions, to the Center for Global Health and the Division of Clinical Public Health, and to Shaza Fidel and Rhea Palma for helping to set up this seminar. I hope everybody keeps well, and we'll be in touch again soon. This has been recorded and it will be up on the Dalla YouTube link very shortly. So thank you, and I wish you all good health and a good day. Cheers.
Everyone.
Thank you.